Hi, this is Dr. Woda, and this is your wrap-up video about post-op care. So typically after someone has any type of procedure or surgery, we're doing frequent vital signs. And a lot of times it's Q 15 minutes times 4, Q 30 times 2, Q hour times 2, Q 4 times 24, then Q 8. Now, of course, that may vary according to your institution, but those are kind of the general guidelines. Other things we have here are some call parameters that you would want to memorize. Now, of course, they might be slightly different at some sites, but for this class, we want you to memorize these. And so, although these come up in the post-operative care section, these are things that you want to think about for the entire semester. So, regardless of what we're talking about, these should kind of be ingrained in your head. Of course, sometimes things will be slightly different if maybe you're on a cardiac unit and maybe they're going to let the blood pressure be a little higher or a little lower. But generally, these are the ones that you're going to want to memorize. So make sure to memorize these. Next, we're going to talk about the different body systems. And although you have a PowerPoint that might have lots and lots of information, we're going to keep it right in the context of this particular picture. So you can kind of think about all of the things that might be happening for this person that could be related to some post-op complications. And although it's focused on post-op, again, I want you to think about the bigger picture that if you're experiencing any of these complications with other problems, you would be kind of doing the same type of intervention. So although this is focused on post-op, this is really for any types of problems. So we'll focus first kind of on respiratory because we're always worried about, airway. That's kind of important to us. So when we're thinking about airway obstruction, hypoxemia, hypoventilation, we're wanting to make sure that our patients are oxygenated, that they have a good airway. And remember, sometimes the first sign and symptom of hypoxemia and hypoxia is confusion. So we want to make sure if we have someone who's all of a sudden confused, who wasn't before, we want to make sure that we are doing something about that. So whether that's increasing oxygen, changing position, coughing and deep breathing, waking up the patient, maybe if they are too sedated, they need some Narcan. So different things like that. But coughing and deep breathing and monitoring whether or not somebody needs oxygen is very important. So we got our airway and our breathing. When we then think about circulation, we're thinking about, cardiac, and a lot of times after any types of surgeries or procedures, especially things that might have impacted those electrolytes, we might have patients who are at risk for dysrhythmias. So we want to make sure that we are monitoring electrolytes, our patients are on telemetry, and we are monitoring that and treating as things arise. Other things, hemorrhage, of course, is always a complication of any type of surgery. So a lot of times if someone is hemorrhaging, we're going to be seeing hemodynamic changes such as increase in heart rate and decrease in blood pressure. So we're going to be watching that. So our hypotension, if a patient is hypotensive post-procedure, it could be related to hemorrhage. It could be related to loss of fluids. It could be related to fluid shifts. So we may be increasing fluids for patients afterwards who are hypotensive. Sometimes patients that are hypertensive could be for a lot of different reasons. Could it be pain? Could be related to urinary retention, bladder distension. So again, we want to try to treat the cause, and it might be that we're going to treat the pain first and see if the blood pressure comes down. If not, we'd be working with our provider to help bring the blood pressure down. Phlebitis can happen from intravenous peripheral IV catheter sites, and venous thromboembolisms, DVTs, PEs are complications that can occur as well. Typically, DVTs and PEs are not going to be, of course, anyone can throw a clot right away during a surgery and you could have a PE, but most of the time, DVTs are not going to show up till after the patient is out of the hospital, so it might be coming back with a post-operative DVT, but that is something to watch for. So we want to make sure that we know the signs and symptoms of PE and DVT as a complication that we'd be watching for. On the bottom here, we have, fluid and electrolyte imbalances. And so those, again, can show up in a lot of different ways. So if we have fluid overload, remember some of the signs and symptoms of fluid overload could be related to respiratory. So we have crackles, and then it could also have some hypoxemia, atelectasis, so we're watching for that. Fluid volume deficit, we might be seeing some problems with cardiovascular. So if someone is now dehydrated, we could have the hypotension, and then the electrolyte imbalances could impact dysrhythmias, and then any acid-base imbalances could be, we could be seeing some respiratory and metabolic changes as well. Also with electrolytes, we can have some neurological problems as well. And same with fluid overload and fluid volume deficit, we can see some neurological things going on there as well. So we have a lot of different things kind of overlapping that might be problems for us. So neurologically wise though, a lot of times, right after in the post-operative period, we're, looking more at some maybe wake-up delirium, over sedation. So again, we're making sure that the patient has oxygen on, that we are decreasing the amount of narcotics or opioids they might be getting. Looking at, patients sometimes after getting sedation can be having some neurological changes as well. A couple days after surgery, again, we have to worry about post-op delirium and things like that. So we will always want to be watching our patients for that, trying to promote good sleep, good nutrition, reorienting them as appropriate as well. Urinary wise, it is very common for patients after procedures or anytime they get any type of sedating medication to have urinary retention. So, urine output may be decreased right after surgery, again, depending on the amount of fluid shifts and fluid loss, or you may see some increase in urine output if they've gotten a lot of fluids. But a lot of times you might see patients retaining a little bit of fluid systemically after procedures or surgery. But if a patient is retaining urine, remember a patient should be urinating within 6 to 8 hours after surgery. And so if they're not, we're going to have to do some type of intervention. So we have an assessment where we're palpating to see if we have any bladder distension, and then we can do a bladder scan. And if we see that the patient is unable to void, we would have to contact our provider to see about some intermittent catheterization. We also have problems with potential urinary tract infection. So if the patient had a catheter placed during their procedure, they would be at risk for urinary CAUTI, catheterization-associated urinary tract infection. Or if we end up having to catheterize them afterwards for urinary retention, again, they have that risk, which, depending on how soon the patient is discharged, may not show up while the patient is still with us, the infection, but we'd want to watch for urinary retention. So that's one of the things, we're thinking about discharging a patient who's had like a day procedure. They have to obviously be alert and oriented. If they came in alert and oriented, obviously if someone comes in whose confusion is their baseline, then we would want to send them home at their baseline. But, they have to be breathing the way they were before they came in. Blood pressure and heart rate need to be stable. They need to be able to urinate. They need to be able to get up and move around. Typically, we'd also be looking at their GI system. And so if they've had a major abdominal surgery or a major surgery where they've been put under for quite an amount of time, then you might see a lot more post-op nausea, vomiting, distension. They may develop an ileus. So remember, when you get sedation, it slows everything down, so you're getting... your GI system will also slow down. And so it can take a while sometimes for your GI tract to start moving again. And so they're at increased risk for a paralytic ileus. So that would kind of go back to, again, watching some of these signs and symptoms there. So the nausea, vomiting, distension can sometimes be related to the sedating medication that they were given, but it can also be related to an ileus. So we need to watch for any type of ileus. And so patients who are nauseated, vomiting, get them moving. We want to give them some anti-nausea medications, increase their fluid and food as tolerated. But again, if we're worried about an ileus, that's when we're watching for those bowel sounds. So typically with any type of surgery, we're making sure that they have bowel sounds before they eat. A lot of times minor procedures, they haven't gotten such large amounts of sedation, so it's not as much of a concern. Although patients can be very nauseated and have vomiting with even very minor sedation, so we just have to watch for that. So watching for any post-op ileus, so early ambulation is going to help, stool softeners, IV fluids, those types of things. In severe cases where we have a bowel obstruction, then you may have someone who's NPO for more of an extended period of time, and may need to get NG tube and things like that. So that'd be a little bit more extreme case. But that's why it's important for us to be watching for any abdominal distension, bowel sounds, those types of things. Hiccups can happen as well. That's a lot of times if irritation of the phrenic nerve, which can happen often more with laparoscopic procedures where the patients are having CO2 to expand the abdominal cavity. You can see hiccups, and those will usually resolve on their own. The other thing to think about is if people are having any shoulder pain, which can occur oftentimes if they're having laparoscopic procedures, and then that CO2 again irritates the phrenic nerve, which can cause that shoulder pain. So laying the patient on their side in the Sims position helps to expel some of that CO2, but that again will just take some time to resolve. So these are some of the kind of major complications when you're thinking about the patient. A patient who's had any type of surgery or procedure could have any or all of these complications. So you're looking at the patient really in a head-to-toe fashion after surgery with, again, a focus on, the area where the surgery is. And so we didn't really say anything about surgical site, but again, that's going to be part of your assessment. And most often, we're not changing that dressing for the first 24 to 48 hours. It depends on the surgery, depends on the provider, and a lot of times the provider is doing the first dressing change. But you're assessing that site. You're looking to see, is there swelling around the dressing? Is there bleeding coming through? Is there a development of a hematoma? Those types of things. And then once the dressing is able to come off and you're doing your dressing changes, typically daily, maybe more often if there's some type of complication, but then you're looking for signs and symptoms of infection, dehiscence, those types of things. So, the assessing the wound site might just be assessing the dressing, or it might be actually assessing the wound depending on when you are in the post-op phase. And again, pain is going to be, we're going to have to treat the pain, and you have a whole nother video that talks about pain. But just remember now, when you're treating these patients with pain medication, the side effects for the pain medication. So, that can, decrease our respiratory rate, decrease our blood pressure, make us confused, slow down our urinary output. Now, not really our output, but cause urinary retention. So you're going to see they may not be urinating. So as you're assessing their urinary output, you actually see that it's being retained. And of course, our narcotics and pain medications can cause nausea and vomiting, but they also cause constipation, which can then also lead to a paralytic ileus. So we have all these kind of things going on with these patients, and so thorough assessment in that post-operative period is extremely important. And like I said before, these principles really can be applied to any patient. If we have someone who's coming in, with other problems, let's say like hemorrhage, then we're worried about some of the cardiovascular things and, their fluid balance status and their electrolytes. So they all kind of do go together. So hopefully this is helpful when you're thinking about your post-operative patient. Thanks.